A cochlear implant, C, is a surgically implanted neuroprosthetic device to provide a person with moderate to profound sensory neural hearing loss a modified sense of sound. C bypasses the normal acoustic hearing process to replace it with electric signals which directly stimulate the auditory nerve. A person with a cochlear implant receiving intensive auditory training may learn to interpret those signals as sound and speech. However, 1/3 of deaf children do not develop language if they are on a C program alone and have no sign language input. The implant has two main components. The outside component is generally worn behind the ear, but could also be attached to clothing, for example, in young children. This component, the sound processor, contains microphones, electronics that include a digital signal processor, DSP, chips, battery, and a coil which transmits the signal to the implant across the skin. The inside component, the actual implant, has a coil to receive signals, electronics, and an array of electrodes which is placed into the cochlea, which stimulate the cochlear nerve. The surgical procedure is performed under general anesthesia. Surgical risks are minimal but can include tinnitus, facial nerve bruising and dizziness. From the early days of implants in the 1970s and the 1980s, speech perception via an implant has steadily increased. Many users of modern implants gain reasonable to good hearing and speech perception skills post-implantation, especially when combined with lip reading. 1-2, however, for prelingually deaf children the risk of not acquiring spoken language even with an implant may be as high as 30%. One of the challenges that remain with these implants is that hearing and speech understanding skills after implantation show a wide range of variation across individual implant users. Factors such as duration and cause of hearing loss, how the implant is situated in the cochlea, the overall health of the cochlear nerve, but also individual capabilities of relearning are considered to contribute to this variation, yet no certain predictive factors are known. Despite providing the ability for hearing and oral speech communication to children and adults with severe to profound hearing loss, there is also controversy around the devices. Much of the strongest objection to cochlear implants has come from the deaf community. For some in the deaf community, cochlear implants are an affront to their culture, which as some view it, is a minority threatened by the hearing majority. André Journow and Charles Eries invented the original cochlear implant in 1957. This original design distributed stimulation using a single channel. 2 years later they went their separate ways due to personal and professional differences. William House also invented a cochlear implant in 1961. In 1964, Blair Simmons and Robert J. White implanted a single-channel electrode in a patient's cochlea at Stanford University. However, research indicated that these single-channel cochlear implants were of limited usefulness because they cannot stimulate different areas of the cochlea at different times to allow differentiation between low and mid to high frequencies as required for detecting speech. NASA engineer Adam Kissia started working in the mid-1970s on what could become the modern cochlear implant. Kissia used his knowledge learned while working as an electronics instrumentation engineer at NASA. This work took place over 3 years, when Kissia would spend his lunch breaks and evenings in Kennedy's Technical Library, studying the impact of engineering principles on the inner ear. In 1977, NASA helped Kissia obtain a patent for the cochlear implant. Kissia later sold the patent rights. The modern multi-channel cochlear implant was independently developed and commercialized by two separate teams, one led by Graham Clark in Australia and another by Ingeborg Hochmeier and her future husband, Erwin Hochmeier in Austria, with the Hochmeier's device first implanted in a person in December 1977 and Clark's in August 1978. Cochlear implants bypass most of the peripheral auditory system which receives sound and converts that sound into movements of hair cells in the cochlea. The inside portion of these hair cells release potassium ions in response to the movement of the hairs, and the potassium in turn stimulates other cells to release the neurotransmitter, glutamate, which makes the cochlear nerve send signals to the brain, which creates the experience of sound. Instead, the devices pick up sound and digitize it, convert that digitized sound into electrical signals, and transmit those signals to electrodes embedded in the cochlea. The electrodes electrically stimulate the cochlear nerve, causing it to send signals to the brain. There are several systems available, but generally they have the following components. External, 1, 2, 3 or more microphones that pick up sound from the environment. A speech processor which selectively filters sound to prioritize audible speech. A transmitter that sends power and the processed sound signals across the skin to the internal device by radio frequency transmission. Internal. A receiver/stimulator, which receives signals from the speech processor and converts them into electric impulses. An electrode or ray embedded in the cochlea.